Earthquake is going to be doing a senior lecture now. All right.
Okay.
All right. So good morning. I took this photo about 5 years ago, the last time I was in India. Wish I could go there, but there's a stupid virus. Yeah, it's really stupid. So we'll start with a case. This is based off the last patient I saw during my downstate block last summer, so before COVID. The note phone rang and we got a note for, quote, rule out cardiogenic shock, which is, I thought, a little bit odd. I'd never heard that as a notification. But I didn't ask too many questions because whoever's on the phone, they're just the messenger. So the patient rolls in. EMS tells you that they were called because she nearly fainted at home. She'd been feeling unwell for a few days, got dizzy today, and then nearly fainted. Doesn't really admit to any other symptoms. They found that she was hypotensive to the 70 systolic. So she got a 500 ml bolus and they got approval from their supervisors to start her on a dopamine drip. Later on, you call the outside hospital where she was at recently, which was actually Kings County, and find out that she has a pretty significant cardiac history. So on your physical exam, she's normotensive, borderline tachycardic, afebrile. Now this is all in the dopamine drip. I don't remember how many mics she was on. She's uncomfortable but not toxic looking. And the other things on her exam, really significant, are she's got some mild crackles at the bilateral bases, some mild lower extremity edema. Extremities are cold. Neuro, she's a little confused, but otherwise grossly normal. I didn't get her up and walk her. So I did a bedside sono. This is right there. Full disclosure, you look at the date here, you see April 18th. So this is a similar patient that I echoed about a month ago in the NICU. So let's see if we can get this to play. How would you interpret this? So the way I would interpret it is there's RV dilatation with intraventricular septal flattening, a D sign. There's also a trace pericardial effusion, right? You guys can see that? Okay. All right, here's the apical four-chamber view. I apologize. I did an echo rotation with Dr. Budarakis, and during that I got in the habit of doing my echoes kind of the cardiologist's way. So everything looks kind of a mirror image, but you should be able to tell pretty easily which side is the right side, which side is the left side. So here's the lung sono, right? No pneumothorax, no B lines. And then the IVC. So with the lung sono, there isn't any findings compatible with pulmonary edema. And the IVC also looks, it's not the greatest of views, but maybe she can take a little bit of volume. And here's your EKG. Spencer, do you want to read this? And there's a wide QRS. When I looked at it, there was nothing that was screaming out to me that there was an occlusive MI. So here's what I did for the patient. So she seemed to have a good squeeze and was normotensive, so I stopped the dopamine. I wanted to see if she needed it, and it's possible that her hemodynamics, having a good squeeze, having normotension, were all due to the dopamine, but dopamine is not your best option for vasopressor, right? I don't know how many people have read this study. If you're early on, it was written in 2010 comparing dopamine and norepinephrine in shock. And they found that dopamine is associated with a greater risk of dysrhythmias like AFib and aflutter, and on subgroup analysis, increased mortality with cardiogenic shock when they compared it with norepinephrine. So I stopped the dopamine. I gave her a 500 ml bolus because I was thinking maybe she's fluid tolerant. And this is the paper. So what's the differential for the patient? I guess there's only 2 interns. Anyone want to say?
So I guess she has signs of right heart strain, even
Okay.
she has the D sign and RV enlargement.
Okay.
Could be a PE,
Okay.
a massive PE with hypotension. Could also be right-sided heart failure, possibly from pulmonary hypertension.
Okay.
Strain. Could be AV dissociation. I'm not sure if I saw PVIDs. Were there obvious PVIDs on the EKG?
No.
Okay, so it didn't exactly look like sinus rhythm, so maybe she has an arrhythmia or a heart block,
Okay.
possibly third-degree heart block. I couldn't tell.
So this is what I came up with on my differential. So PE, right, and myocardial infarction on the right side. She could be dehydrated. That's why she's hypotensive and not enough intravascular volume. Is this a heart failure exacerbation? It's a little less likely. She doesn't have signs of pulmonary edema. You mentioned right ventricular failure and then sepsis. So just think about your diagnostic plan, any labs or imaging that you might want to obtain. Calvin, anything? Okay. Okay. So here are the labs we got for her. I also sent blood cultures besides the things you see here. So this is, let's see. Protein, albumin, AST, ALT, alk-phos, total bilirubin. Here's her blood gas, CBC, and other labs. All right, so the lactate's a little bit elevated. She has an elevated hemoglobin count. This could be a reactive polycythemia, not necessarily just dehydration. So we ordered a CTA chest as well as a chest x-ray to look for a pulmonary embolus. While we were waiting to take her to CT, she became hypotensive to the 60s systolic. So we started on peripheral levofed and placed a central line. All right, so here is the CTA. Yeah, so for the sake of completion, I asked them to get abdominal slices just to look at the aorta, even though I didn't think anything was really wrong with it. But
There's a thrombus in the IVC.
all right, and here are the lung windows. All right, so took this photo also 5 years ago after I finished up in India. Went to China and hiked the Tiger Leaping Gorge. It's really pretty there. So here are the results of the scans. We also got a CT head because she was a little altered, was confused. Didn't show anything acute. I didn't include the images because it's not really relevant. But the thing I want you to take away from this is there is evidence of right ventricular strain. Ronnie brought this up. You see reflux of contrast into hepatic vasculature, but there's no PE. And this is an important point. RV strain doesn't automatically mean PE. It just means RV strain from some underlying cause. PE is one of them. And I would also suggest if you have a patient who has RV strain, you should think seriously about doing a bedside DVT study. It's well within our purview to do that. And if you find it, it increases your pretest probability that the PE is causing their RV strain. And you can start anticoagulating them empirically if they're too unstable to take the CT. So Frisch mentioned a couple of potential other causes for RV strain. Can anyone think of them? Other ones?
Cancer.
How does cancer cause RV strain?
Just bulk of tumor and
So,
obstruction of lung tissue.
okay, so obstruction, okay, okay,
Valvular abnormality.
okay. Who said that? Jordan, good. What else? Okay, RV infarct. So ILD, some sort of pulmonary parenchymal disease. So this was my differential. So an acute PE can cause it, obviously. Pulmonary hypertension, all of these parenchymal diseases, we're talking about pulmonary fibrosis, valvular heart disease, these eventually will cause pulmonary hypertension. RV infarct, pulmonic stenosis, some sort of structural heart disease, bronchospasm, a pneumothorax, and then ARDS is also the differential. We're not necessarily going to see that as much in the emergency department. It's more something they'll see in the ICU over the development of time. But when we did our echo, we didn't see a pneumothorax, or we did ultrasound, we didn't see a pneumothorax, and we have our CAT scan images. So the final diagnosis was RV failure. And based on her cardiac history, we think that it was secondary to pulmonary hypertension from left-sided disease. And so that brings me to my topic, pulmonary hypertension and RV failure. So don't go to sleep on me. I chose this because I find it interesting, but I also think it's important. We don't see it that frequently, or we see it really frequently in the ED. We don't necessarily account for it. This was from our IMSOL session intern year, just after having lunch. Glasgow food coma score 3. So my main objectives today, give a brief overview of pulmonary hypertension. We'll include the various etiologies, the pathophys, clinical manifestations. I'll get into the management of RV failure in the ED because it's not always the same as the management of LV failure. What I'm not going to be talking about is RV failure secondary to ARDS or an acute PE. And the short answer for RV failure management is you take care of the tank, the pump, the pipes, and if possible, treat the underlying cause. So this is just a brief refresher, right? Let's see if I can get the mouse over there. All right, so you have blood comes from the vena cava, SVC, IVC, into the right atrium, goes into the thin-walled RV, and it is pumped into the low-pressure, high-flow pulmonary arteries, gets oxygenated in the lungs, comes back through the pulmonary veins, goes to left atrium, left ventricle, which has a thick wall, and then goes into the systemic vasculature. So these are the pressures of the different chambers. This is systolic, diastolic. Okay. Anyone tell me where the RV gets perfused by? McMahon.
Right quarter.
All right, what's the pressure of the RCA? It's a trick question. It's the same as your systemic pressures, right? So it's going to be 120 over 80. So this actually has some important implications. It means that physiologically, your systemic pressures should always be higher than your RV pressures. So the RCA should be perfusing the RV in systole and diastole, right? When you look at the LV, the systolic blood pressure in the LV, the systolic blood pressure in the systemic vasculature are the same. So that's why you don't get perfusion of the LV during systole. It's just during diastole. One other thing to keep in mind, in the absence of any RV outflow tract obstruction, the pulmonary artery systolic pressure is equivalent to the RV systolic pressure. And we talked about this a little bit. Systemic vascular resistance is greater than pulmonary vascular resistance. In pulmonary hypertension, the mean pulmonary artery pressure is greater than 25 millimeters. That's measured on right heart cath. We're obviously not doing right heart caths in the emergency department. But when you do an echo and you see a RV systolic pressure of more than 35 millimeters, that suggests pulmonary hypertension. You can calculate the RV systolic pressure by looking at the tricuspid valve regurgitant jets. On your echo, there are a few different views, your apical four-chamber. There's an RV inflow view that you obtain by looking at a parasternal long view. And then there's a parasternal short at the level of the aortic valve leaflets, just a little bit more caudal to where you see the mitral valve. I can show any of you guys individually if you're interested more. But the problems with pulmonary hypertension, they arise when the pulmonary vessels become hypertensive, right? Obviously. So you have increased pressures in the pulmonary vasculature. Let's see if we can get this here. It decreases the RV stroke volume, and then you get increased RV overload. And what that causes is bulging of the intraventricular septum into the LV. This whole phenomenon of the septums is called intraventricular interdependence. So when you have bulging of the septum into the LV, then you're going to have decreased LV filling. And so that's going to decrease your cardiac output. You're going to get decreased RV perfusion because that's less blood that's going to go into the RCA. And it becomes a vicious cycle, right? At the same time, as you have increased RV afterload, you're going to, over time, get RV hypertrophy, RV dilatation. That increases your wall stress and also decreases your perfusion of the RCA. And it becomes a vicious cycle. Keep in mind that the RV has less acute reserve because it's so thin-walled. So any disruption to the patient's homeostasis can cause them to fail acutely. So things like an acid-based derangement, hypovolemia, some tachydysrhythmia, hypoxemia, sepsis. And in this situation, your SVR to PVR ratio decreases. So there are a myriad of causes for pulmonary hypertension. They're broadly broken down into 5 categories. I'm doing internal medicine board review right now, and I've gotten a few questions on pulmonary hypertension. So maybe the EMIMs will have to learn this at some point. For the EM people, you don't need to memorize the exact things that fall into the causes, but it does give you a clue as to what the treatment's going to be, because depending on the cause, that's going to guide your treatment. You can broadly break it down into 5. So group 1 used to be called primary pulmonary hypertension. It's vascular remodeling. You have some sort of idiopathic connective tissue disorder, a familial disorder, and HIV, congenital disease. It causes vascular remodeling, and the way you diagnose it is they have a right heart cath, and they calculate the pulmonary capillary wedge pressure, and it's less than 15 millimeters mercury. The therapies that you guys heard of in medical school, like Bosentan, sildenafil, these are mostly approved for group 1 pulmonary hypertension. Group 2 is LV disease secondary, or RV disease secondary to LV disease. So heart failure causing backup, either volume or pressure backup into the right side of the heart. This is what our patient probably had. Group 3 is pulmonary, so hypoxic disorders, lung parenchymal disorders, pulmonary fibrosis, etc. Group 4 is thromboembolism. So you guys have probably read about potentially pushing TPA for submassive PEs. The idea is to try and prevent the development of group 4 pulmonary hypertension. And then group 5 is basically everything else. Multifactorial mechanisms, sarcoidosis, vasculitis, lupus, rheumatoid arthritis, sickle cell disease. A lot of our sickle cell patients who end up surviving long enough to get into their 50s are going to develop pulmonary hypertension as a result of that chronic pulmonary vasoconstriction. Dr. Z pimped me on this a few years ago. I haven't forgotten it. It's basically following the alphabet: A, C, P, T, and then everything else. Whatever works for you. I'm just scared of him. That's a Mickey, Dr. Z, not you. So here are some of the symptoms that you can see on the chief complaint, people with pulmonary hypertension. And this looks like almost everyone we see in the ER, right? Dyspnea, chest pain, abdominal pain, weakness, fatigue, presyncope, dizziness. They actually did a retrospective study looking at patients who had a known history of pulmonary hypertension who went to Mass General ER, and it was over a 21-month period. And their most common chief complaints, the 3 most common, were dyspnea, chest pain, and abdominal pain. And it was consistent between overall visits, for return visits, and then also for visits of those who they characterized as high utilizers. So it's really nonspecific. The key thing is to have an index of suspicion for it. I would suspect that a decent number of the patients we end up placing on observation or admitting to the hospital for rule out ACS, quote unquote, their symptoms were from worsening pulmonary hypertension. So in the early stages of pulmonary hypertension, your exam isn't going to be too helpful, but as you get later, you should see signs of RV failure. So volume backup into the venous system. So maybe things like JVD, hepatojugular reflex, congestive hepatopathy, right? Ronnie brought this up, he saw it on the CAT scan, ascites, hepatomegaly, LFT derangements. Auscultation may or may not be helpful on your physical exam. One of the papers that I'll go into in the next slide, they mentioned high specificities for things like an S4 on inspiration or allowed inspiratory P2, S2, which you can see with pediatric patients. An RV lift on inspiration, I'm not entirely sure what that is. I can tell you in the past couple of months, I haven't really used my stethoscope an awful lot with COVID. And I haven't really heard an inspiratory S4. So this is that study. It's a lot of stuff on this slide. Just note that the data is really, really old and there's a wide variance. So the authors who did this review, they tried to reproduce the results of their review and did their own prospective study. So they had 52 patients in their hospital who had undergone a right heart cath for whatever reason. So they had the actual measured values. And then they did their physical exam. And there were 3 specialists. These were either cardiologists or pulmonologists, and then 3 generalists. And when you take into account the pooled results of all of the examiners, the physical exam finding that had the highest positive likelihood ratio was allowed inspiratory P2, and even that is less than 2. It's pretty insignificant. Now, eventually, decompensated RV failure will cause LV failure too, right? Cardiogenic shock. You're not going to be pumping blood from the right side to the left side, and so it won't go to systemic vasculature. So you're going to see signs of cardiogenic shock, hypotension, cool extremities, diaphoresis, peripheral cyanosis, tachycardia. In terms of studies to get, you can get the same things you get for everybody: CBC, COMP, TROPES, BNP, blood gas, but use your clinical judgment like you should do for everybody else to guide what labs you obtain. When you see TROPES that are elevated, they're going to indicate decreased myocardial perfusion, obviously. Elevated LFTs are going to demonstrate decreased cardiac output, RV backflow. So both of these are going to indicate a poor prognosis. You might see hypoxemia with a resultant respiratory alkalosis in the blood gas, and the CBC might show an increased hemoglobin, reactive polycythemia. ECG might show right atrial enlargement or right heart strain. That's like ST depression or T-wave inversions in the precordial leads. Here's an example of one, like the caption says. There's signs of right ventricular hypertrophy with strain. There's a QR, let's see, get this in V1. Other things you can find, you can see in right axis deviation. Don't really have that here. Right bundle branch block, tall R's in V1, V2, an RSR prime in V1, large inferior P waves. Chest X-ray might show dilated pulmonary arteries are enlarged right side of the heart, but it's only helpful if it's gotten to be severe. And then a CT scan might show possible etiologies behind the pulmonary hypertension. It can show you if there's a pulmonary embolus, if there's some sort of lung parenchymal pathology, chronic pulmonary edema that would point towards some sort of cardiac pathology. The papers all mentioned ground glass opacities. I'm pretty sick of seeing that phrase. And then the echo, I think, is going to be your most helpful diagnostic modality at the bedside. Dr. Sinnert is nodding his head. From the ED perspective, the two most useful views are going to be your parasternal short and your apical forechamber. So on the parasternal short, again, you can look for septal flattening, which makes the LV D-shaped. Normally, it's supposed to look circular. The way I think about it is your LV is like a bullet, and the right side of the heart is almost wrapping around it. In general, volume overload should cause septal flattening in end diastole because RV pressure is going to be greater than LV pressure at that point. Pressure overload, you should see septal flattening in systole. Again, this is interventricular dependence. Bulging the septum into the LV decreases LV filling, decreases cardiac output, and D sign does not equal PE. On the apical forechamber, you can look at the size of the ventricles with respect to one another, as well as RV wall thickness. So typically your RV should be about 2/3 the size of the LV, and wall thickness ranges, according to like the echocardiographers. It should be about 5 millimeters is RV wall, free wall thickness. LV free wall thickness should be about 10 millimeters, so 1 centimeter. These are obviously all ranges, and there's going to be variance. But another thing that the apical 4 lets you do is calculate a TAPSE. So that stands for tricuspid annular plane systolic excursion. So you're looking at the lateral annulus of the tricuspid valve on your apical 4, look at it in M mode, and you're measuring with each right ventricular contraction how much that annulus moves. So in normal systolic function, you should expect quite a bit of movement, more than 1.6 centimeters. Anything less than that suggests RV, decreased RV systolic function. And then there's also the IVC. These are also some numbers from the echocardiographers for measuring right atrial pressure. You look at the IVC. Whenever you guys have looked at echoes, doing your chart review of previous patients, they might say pulmonary artery systolic pressure is equal to some number plus right atrial pressure. And this is how they calculate right atrial pressure based on this. In the ER, we tend to look at it more qualitatively rather than quantitatively, though. And these numbers aren't as accurate when a patient is ventilated. All right, stay with me. So while treatment of RV failure is a lot in common with treatment of any other critically ill patient, there are a few unique considerations. I like to think of it like the rush exam. So you have the pump, right? That's the RV. You have the pipes, that's the pulmonary vasculature. And you have the tank, that's the overall systemic vasculature, the intravascular volume. And just keep in mind these physiologic relationships between MAP, cardiac output, systemic vascular resistance, heart rate, and stroke volume. Our interventions for critically ill patients are all geared towards these. So when we give a person IV fluids, we're trying to increase their stroke volume. When we give them vasopressors, we're going at their systemic vascular resistance. Inotropes, dobutamine, that affects cardiac output by both going at heart rate and stroke volume. So these patients, they are preload dependent. What makes it even more difficult is physical exam assessment of volume status can be really, really unreliable for patients with pulmonary hypertension. When you give them lots of volume, it's going to increase RV wall stress. And due to that intraventricular dependence, you're going to decrease LV filling and thus cardiac output. So if you have a patient who had a lactate because of decreased perfusion, and it's because of this ventricular interdependence, then you give them fluids. Fluids are actually going to make it worse. Does that make sense? At the same time, if you over-diurese them, you're going to decrease their intravascular volume, and you could also decrease their cardiac output the same way. So one approach is to give small boluses of fluids, say 250 mils at a time, if the patient is mildly hypertensive, to try and fill the tank. You can do serial physical exams, ultrasound reassessments, looking for lower extremity edema and a plump IVC. But just remember that by themselves, they don't necessarily indicate that the person is fluid overloaded. They'll point towards an elevated right atrial pressure. It's really about seeing how these things change over time. If it's a patient who you're concerned might be volume overloaded based on your clinical exam, then you can try careful diuresis, like small doses of Lasix. It's a situation where history is going to guide you, and serial reevaluations are going to be key. It's all about finding that happy balance. This was the easiest pop culture reference to Goldilocks and the Three Bears I could find. This is before like the credits. They end up killing Homer and eating him instead of the porridge. So we've taken care of preload. Next step is to optimize RV perfusion. So remember, the coronary arteries get their blood supply during diastole, right? The aortic valve closes, the backflow goes to the coronary arteries. If the pulmonary artery pressure and RV systolic pressure get larger than the systemic pressure, then that pressure gradient between the RV and the coronary arteries is lost, and you're going to have RV ischemia. So you want to maintain that ratio, SVR being greater than PVR. So one thing to do is maybe start vasopressors. Think of this as like when you have a patient who has increased ICP, you give them vasopressors to increase their MAP so that that cerebral perfusion pressure, that gradient between their MAP and ICP, allows for them to perfuse the brain. Here are some of the effects on cardiac index, pulmonary vascular resistance, and systemic vascular resistance for a bunch of the vasopressors and inotropes. Remember that RV systolic pressure is essentially equivalent to pulmonary artery pressure, so it's all about restoring that balance. We talked about norepinephrine. One of the downsides of norepinephrine is at high doses, it's going to also increase your pulmonary vascular resistance. And so the help that you get from increasing the SVR could be lost. Another option is using epinephrine. Remember, epinephrine at low doses also has some beta receptor stimulation, and there are beta receptors in the pulmonary vasculature. So yeah.
Is there any downside to using epior because it causes a higher heart rate and gives you less time in diastole?
That is one of the considerations you have to think about. And then you have low-dose vasopressin. That has been suggested that it causes the production of endothelial nitric oxide, and that decreases pulmonary vascular resistance. This is at like the low doses, 0.03, 0.04. So you've addressed the SVR part of that ratio. Next, we want to look at the PVR. And we do that by, can give supplemental oxygen. So that is going to help with pulmonary vasodilatation. Normally, right, our lung vessels, they're going to vasoconstrict when we're hypoxic to divert blood to the places that are being ventilated. You can try NIPPV, non-invasive positive pressure ventilation, for a patient with group 2 or group 3. So that's secondary to cardiac or secondary to a pulmonary etiology, CPAP or BiPAP, to try and help with oxygenation. But just remember that the positive pressure that you're giving them can also have a negative effect on their preload. That same reason you want to try to avoid intubation unless it's absolutely necessary, because they're preload dependent. Intubating them and giving them positive pressure could easily precipitate hemodynamic collapse. Another option is high flow nasal cannula, because it gives you a higher FiO2 at a sum PEEP, but not nearly at levels as drastic as CPAP or BiPAP. There's also some evidence that acute hypercapnia is going to increase pulmonary artery pressures. Some of the papers prior to publication of the ARDSNet trial showed this when they were testing out a lung protective strategy. And then there's also some evidence that acidosis increases pulmonary vascular resistance. So giving a patient bronchodilators actually can attack this at in two directions. It helps with a respiratory acidosis, or it can help with respiratory compensation for a metabolic acidosis by increasing that interface for gas exchange. And then you can also try pulmonary vasodilators. You guys have heard of nitric oxide, right? There's a picture outside in the hallway. Robert Furchtgott won the Nobel Prize for discovering the physiologic basis of nitric oxide. It does increase oxygenation and hypoxic respiratory failure, but there was a Cochrane review about 4 years ago that didn't show any mortality benefit. The main disadvantage, apart from the fact that it doesn't show any mortality benefit, is it's expensive and it's difficult to obtain, but we have another option. When I was a kid, maybe I'm dating myself, I used to watch Looney Tunes, and I see nitroglycerin, I think of like Wile E. Coyote trying to get the Roadrunner and blowing himself up. But nitroglycerin is metabolized into nitric oxide. That's how it works for us. So there was a post in MCRIT about 6 months ago. Josh Farkas, who's a pulm critical care physician in Vermont, talked about using inhaled nitroglycerin for the treatment of massive PE. There was also an MRAP, a presentation on that, nitro inhaled for massive PE treatment. Farkas went over some of the papers about inhaled nitro. The big limitations where they were all related to post-op mitral valve replacement, pediatric patients, or they were in animal studies. There aren't any good RCTs for crashing RV failure patient, so the evidence is not very good. But it's something within our armamentarium, and one of the things that was a take-home was it seems to have less of an effect on the systemic vascular resistance when it's inhaled. It stays more in the pulmonary vasculature. So you decrease the PVR. You're giving it with oxygen. That's also going to decrease the PVR. The doses they suggest are like 2.5 to 5 mics per kg per minute, which translates on average to about 5 mgs over 15 minutes. At Kings County, our bottles are 250 mics per mil, which should equate to about 20 milliliters. We're obviously discouraged from giving nebulized medications right now in COVID, but just think about it, it's a tool that's there. Other medications here, there's a lot of them. They're mainly used for treatment of patients with group 1 pulmonary hypertension, and their main role in the ED is really when you have patients who are having rebound pulmonary hypertension from not taking their meds, to give it to them in that situation. It's not something we should routinely be giving out to patients. So you'll notice I never spoke specifically about optimizing the pump. I talked about the pipes and the tank, but that's because if you appropriately maintain RV perfusion and decrease RV afterload, that in and itself should increase RV cardiac output and treat the pump. So you should be wary of starting inotropes, like Dr. Silverberg was saying, epinephrines, inotropic activity. For RV failure patients, until you've already addressed RV perfusion and RV afterload. Some other considerations, just be mindful of anemia. This is going to decrease overall oxygen carrying capacity, cause more vasoconstriction, and cause RV ischemia. These RV failure patients are also more prone to developing tachydysrhythmias like flutter and fib, and our rate control medications have an adverse effect on cardiac contractility. So just be mindful of that. You might be more likely to cardiovert them. This is a situation where loading the boat might not be a bad idea, calling the cardiology colleagues. And then in terms of disposition, you're essentially going to use the same criteria used for any other patient. Someone who has a worsening functional status, they're newly diagnosed with advanced pulmonary hypertension, or some other reason related to their underlying etiology. They have a submassive PE. You're probably not going to send them home. So to summarize, first step towards treating the problem is acknowledging that it exists. Pulmonary hypertension is a disease we don't often pay much attention to. And although I don't know the exact numbers, I think we have a pretty high prevalence in our patient population. And with COVID and all of its complications, I think that's going to go up. So just be aware that it exists and think about it. Remember that the clinical presentation can be really nonspecific. And your echo and other imaging modalities can be super helpful. And then when you're managing the patients, remember to treat the tank, the pipes, and the pump. And then finally, D-sign does not mean PE. All right, so thanks to Drs. D'Souza, Willis, and Conrad for helping me to make this presentation. Dr. Budarakis for helping to teach me how to do good echocardiograms, and Dr. Beta for helping me tease out this topic. But over the last 5 years, special thanks to this group of people I got to start out with, this group of people I get to finish up with, and above all, these two who helped me through some of the hardest moments of residency, especially the past few months. Could not have done this without them. Questions?
I actually looked at a bit about nitric oxide just because I have an outside company that I sort of do consulting with. The only way to get it right now is through canisters or tanks where you can inhale it. But this company actually builds a machine that splits it out of the air. So you can actually have a machine that runs it constantly. So you don't have to buy tanks and constantly get them refilled and brought in. Nitric oxide also has some sort of antiviral effects on different pulmonary pathogens. I'm not sure how good it is or not, but they're experimenting with that now. That's why I'm consulting with them during the COVID times. It looks promising, but I don't think anybody knows the real answer yet. But if anybody has more questions about it, I can have you talk to their people and see what else you want to learn about it. It looks promising, but I'm not sure yet.
Is there any mortality benefit to it though?
To nitric oxide?
Yeah, inhale.
I mean, the Cochrane review 4 years ago said no.
Yeah, exactly. Right. Because I mean, even and that was not even just inhale. That was the normal dilators. I think that's the stinks the most about pulmonary hypertension.
It's a bad disease.
It's awful. You feel terrible. You get nowhere with it. We know all the science and we do nothing about it. And right, there used to be just a little bit of evidence that mortality should improve with like the prostatal continuous effusions, and that was really it. That's really expensive, and I got that plenty of time before, and who knows how much mortality benefit it really gives. But that was the only one. So all this stuff just doesn't seem to work. So
I think we see a lot of it that we don't realize.
yeah,
We miss it all quite often. I think one of the tip-offs that we saw and we didn't mention is that high hemoglobin.
The reactive polycythemia.
Yeah, from chronic hypoxia. I think that's a tip-off that they have chronic pulmonary hypertension and not something to do. So make sure you notice that so we didn't talk.
I do think the biggest thing is, right, when you look at all those groups of what causes pulmonary hypertension, right, a bunch of those groups are things we can manage earlier on, right? All the cardiac causes, the pulmonary causes, and the chronic venous embolism. We diagnose them early enough to manage it appropriately. So I think our biggest weapon in fighting this is just preventing it in the first place and trying to get patients the right access to long-term care and us doing the right things in terms of diagnosis and making sure we're managing their underlying health problems. There's not much you can do about the idiopathic. There's all these things, but it hasn't panned out over all these years.
Like still benefit levels only really work in kids with pulmonary hypertension, not so much as from adults.
And it doesn't usually even have mortality benefits. It helps with symptoms, right? So that's great because your quality of life improves. But in terms of the length of your life, it doesn't seem to help in the long run. And even then, there's so many. You have to do the right heart cath and CT and respond to those in the first place. And a good chunk of our patients, when we do right such heart cath, they're non-responders, so they don't even start on it because it doesn't seem to even improve their symptoms that much. So.
We get a lot of them actually, those chronic dyspneas who come in with shortness of breath, and no matter, and we get an echo that's no B lines, we get a chest X-ray that's clear, but we're like admit for CHF exacerbation, Lasix and whatever, and we put them on for 3 days.
Yes, not the right thing.
Yeah.
We see that quite a bit.
Yeah, I think that's the most important thing about this lecture is being able to identify that and potentially just sending that patient home, not CTing or not doing all these things, looking for maybe an underlying exacerbating etiology, treat that, and then
Home oxygen. Home oxygen is this is the best thing we can do.
Yeah.
Perfect. So what about do you find anything about moderate levels of BNP? It's someone's going to look at this patient. Oh, this patient doesn't have CHF with BNP 347.
There was some of the papers mentioned like a level above 300 having a negative, as a negative prognostic factor, but that was really all I could see with
I think
respect
it's
to
because
BNP.
the RV is big enough,
Yes.
or the RA is big enough to generate enough. Because right now it's very skinny. So once it gets bigger, it can generate enough BNP. That's why it's a bad prognostic. That's not the right way.
I think just to piggyback on the prevention that everyone was talking about, I think the other important thing is probably need is also important. Just as important, not the said few things that were don't aggressively say, it's CHF, what's diagnosis, because when you accept the patient hours later, that patient is back, and something else can go along with that patient. And I think that's something that we need to remind ourselves of, that is a possibility.
That's a really good point, because if you give them the Lasix, they lose their stretch, and then their right side is very load dependent, and they end up crashing later on. So remember that pulmonary fibrosis can look like D lines on sono, so it's sometimes hard to discern.
And just for closing our discussion, so, any patient comes in with what you think is a pulmonary hypertension exacerbation, having any kind of dyspnea, it's already the start of probably the downward cycle. And it's a very slow, very miserable, and it's a lot of suffering for these patients. It's awful.
You know who they are. The people who come in and their current complaint is always dyspnea, and they're not fluid overloaded. Like they're coming in once a week, they dyspnea because they don't understand that this is their new baseline, and they're not actually going to recover back to the way they were a couple months.
Yeah, no one's going to come in and say, chest pain, hypertension.
Not many.
It has to come out.
Every time anybody mentions that study that showed dopamine increased mortality, I feel the need to protect or defend dopamine. That study was done in ICU, and most patients were on dopamine for a long time. So I think if you still need an inotrope, dopamine is a decent inotrope that you can use, knowing that it's not only an inotrope but also a chronotrope, so it's going to increase the heart rate and might increase the oxygen demand. If you can't use dobutamine, then dopamine still for short term in the ED is a useful inotrope.
I feel like I get these patients and realize a little too late because they have like overlying issues. So you're treating the CHF and the COPD, and then a lot of times I'll look at their echo and I'll look at like the PASP and the right heart analysis. Is there anything else you recommend that would hint us earlier, like when we're chart reviewing, aside from like the obvious, that would kind of help us get to that conclusion a little bit faster?
I mean, Not really. Having the PASP there is probably going to be the most helpful thing. The gold standard for diagnosis is a right heart cath.
Yeah.
They don't do that too often anymore.
Yeah, I think just remembering that, right, if the patient is long-standing COPD, long-standing left-sided heart failure, it seems not to be controlled, just remember in the back of your mind, the fact that you have to back at all the symptoms. Those are probably the two most common things that our patients have that lead us to pulmonary hypertension. Is underlying COPD and left-sided heart failure. And there's all the other things too that we see. We'll see patients with chronic rheumatic embolism and stuff like that. Sarcoid, lupus, interstitial lung disease. We see all those things too, but I think really just looking at the DASP and then just remembering keeping your differential wide with the patients coming in with frequent COPD exacerbations or frequent. It seems like maybe CHF related shortness of breath that there could be an element of pulmonary hypertension. It's fair, yeah, especially if you're seeing like numbers over 50 or over, that's high on a transference echo. So when I start seeing the 45 to 50 numbers, I start to take that a little more seriously. Right, anything over 35 is still probably positive, but as we start getting into the 40s and the 50s,
Your pretest probability goes up dramatically.
It's actually a really good suggestion too. It's something that I used to do on Optima. Is you find their echoes, like look at the pulmonary pressure, the estimated pulmonary pressure on the echo. When you get these people, you can go back to the previous echo, or give you a sense if it was pulmonary hypertension that might have been missed or overlooked, and they didn't get referred to Palm right away for treatment.
Yeah, and that's really where I use it, just for Palm, so that they can do more basic testing or TEEs if they think it's going to be more accurate measuring pressures. And home oxygen, yeah, it's one of the few things.
And that'll keep them out of the hospital.
Yes.
It will.
It'll make
I mean, that's what they're here for, is they're here for hypoxia.
It's the only thing that helps,
It's the
like
only thing
increases
that makes it
mortality and decreases mortality in COPD. Alex.
If you guys ever want to join us on Scansion,
It's really important to treat the underlying cause of the pulmonary hypertension. So a lot of the treatments that we talk about, you know, the fancy stuff that we're never going to start in the ED, that's for kind of pulmonary hypertension. And underlying cause, whether that's AFib or COPD, is really the key. And as is mentioned, I think I heard it, it wasn't so clear maybe for the people at home, is that a lot of the times these patients are diagnosed with CHF or they're treated for CHF because they're going to come in short of breath with peripheral edema, kind of a lot of peripheral edema, and their BNP is going to be elevated, but you have to have some of a index of suspicion. And this is where your bedside ultrasound is really going to come into play, because you can be like, oh, this person has CHF, but their LV function is not that bad. Obviously, if their RV failure is secondary to LV failure, that's a different story. But for the patients who have primarily a pulmonary hypertension or an RV failure as their problem rather than an LV failure, it's really important to identify them so they can be treated and worked up appropriately.
I was just saying that if you guys want to brush up on the echo skills, you're more than welcome to join me. Scan it tomorrow. You can go through everything that you like. I'm happy to spread it.
All right. Any other questions? All right. Thank you.